So we're going to talk about the PMTCT guidelines, and it's the section that has the most nuances and the most complex bits, and probably the most revisions as well in terms of the new guidelines. So in terms of the outlines, we'll talk about the PMTCT pathway, both during the antenatal period and the postpartum period, and then also just give a lot of detail on what the new interventions are as we're looking at the mother-infant pair. And one of the emphasis with this part of the guidelines is the integration of looking after the mother and looking after the infant, and also the integration of family planning. So obviously, the big things that we're looking for viral load suppression at the time of delivery, and also viral load suppression during breastfeeding and in the postpartum period. I know in Julia's section, we went through a few slides and then we asked questions. Do you want us to do that? Or do you want to stop me and ask questions? Go through a few slides and then ask questions. Okay, we'll do that. So in order for the pregnant woman to be virally suppressed at the time of delivery, I know it's one of the things we don't do very well. Most of our pregnancies are unplanned, and they're not specific to the HIV positive woman. Even our HIV negative woman, most of the pregnancies are unplanned. And also booking into antenatal care, I know we're doing a bit better in terms of women who book before 20 weeks. Ideally, women should book in the first trimester. Now we have Bank Plus, where we need a minimum of 8 antenatal visits during pregnancy. And also for women to be diagnosed early during pregnancy, it's a part that we've been doing well. Same-day initiation for those that are identified as HIV positive, retention in care during antenatal period, good adherence, and then we get viral suppression. And then in the postpartum, intrapartum and postpartum period, reduce MTCT during delivery, link the mother to care after delivery, good adherence, and then viral load monitoring and the response. You've gone through the ABCDE several times this morning, applies to the pregnant woman as well. So we're talking about this integration of ART services and family planning. Again, they've been very separate services, but now if we're giving dolutegravir in the women of childbearing age, we need to integrate the two services. And we also talk about safe conception. Remember, safe conception is for the HIV positive woman or the HIV negative woman with a positive partner. And safe conception means that you prevent infecting the negative partner and also prevent mother-to-child transmission. So it's all part of us having a good PMTCT program. So again, you've gone through this several times during the course of the morning, is that at every visit, if you're with a woman of childbearing age, you talk about her pregnancy intentions. If she's using contraception, it's reliable contraception. If she desires a future pregnancy, when does she want the pregnancy? So in terms of HIV test at first antenatal booking, that stays the same. Every woman who books who's HIV positive gets an HIV test. What's changed is the timing of the repeat HIV test during pregnancy. Anyone want to warrant why it's changed? Because? Yes, because now that our antenatal PMTCT program has been doing so well, majority of our transmission are happening in women who seroconvert, either during pregnancy or during breastfeeding. So the new guideline now is saying that the HIV test is done at every full bank visit. I know with the new bank schedule is that in the 3rd trimester, there are more frequent antenatal visits, and even if a woman has got a higher risk profile, they may be coming to the clinic every week. But what we're saying that you're not going to be doing an HIV test every week. So you'll do the HIV test at the full bank visit, which is every month. And then it's done at labor and delivery, as we've been doing. And then the change again is that previously we were doing a repeat test at 6 weeks. Now it's at 10 weeks after delivery to align it with the 10-week visit of the infant. And again, talking about integration of the mother-infant pair. And then 3 monthly during breastfeeding hasn't changed. And then same-day initiation, we've been doing same-day initiation, but the important thing is timing of the ART initiation. Remember, especially for the pregnant woman, is that the earlier you start your ARVs, the more likely you're going to get viral suppression at the time of delivery, which is the most high-risk period in terms of mother-to-child transmission. Okay. And then potency of the regimen, we've talked about the different regimens and the benefits of using dolutegravir in terms of rapid viral suppression, less side effect profile. We're still going to talk about that in detail. And then obviously safety of the regimen. We talked about some of the things, we'll reiterate them again. So you've heard about the new kid on the block, all the benefits of using it, but the concerns. Biggest concern is about neural tube defects, and the people who've been in the program for long enough know that we went through the same thing with efavirenz, that there was a risk of neural tube defects, and then as more evidence was gathered, it became obvious that actually the risk was not there, and we're able to use efavirenz. And we're hoping that it will be the same with dolutegravir, as evidence increases and more people are using it, it will actually not show an increased risk. And I know you talked about the study before. The difference was in the non-dolutegravir group, there's 1 in 1,000 babies that had neural tube defects. In the dolutegravir group, it was 7 in 1,000, which is much higher. And remember, we live in a very litigious group. The Gauteng group will tell you that I don't know how many billions that have been spent on litigation in the country. So that's why the counseling is going to need to be so important, because we dare get 1 neural tube defect in a woman who've been put on dolutegravir, we're going to be in trouble. Okay. And that's a caution about what are the fertility intentions, when are they planning to have a pregnancy. It again influences your choice of contraception, is that you want something short-acting, long-acting contraception, depending on the planned pregnancies. And again, we talk about the informed choice. One of the things we haven't really emphasized is training of counselors, because we know the reality in our facilities that how many patients do our midwives see in a day? How much time do they spend with a pregnant woman? How much counseling is done with a pregnant woman? And also our primary healthcare nurses as well. Because if you look at all this information, how much time do you need to take with each patient, asking, when are you planning to fall pregnant? What contraception are you using? Do you know those risks? Do you understand this risk? You write in the notes. You might make a sign as well. And how possible is that? So as part of cascading down your training in the provinces, you're going to need to schedule training for the counselors and make sure that we train them very well, as well as your health promoters, because by the time the woman comes into your consulting room, they should have all this information, or at least the majority of the information. And we've gone through this again, just to reiterate, is that the patient makes an informed choice. And somebody had made a good example yesterday, is that a lot of the time, when you're counseling a patient, you'll say, you need to do this, you need to do this. These are the risks and benefit, what you want. And what does the patient turn around and say? What do you think, doctor? What should I do? So we can't do here what do I do, because as I said again, is that we dare get 1 neural tube defect, the patient will turn around and say, the doctor said I should start dolutegravir. Okay. So we need to make sure that we counsel the patients very well. We've gone through those risks and benefits. I'm just going to talk a little bit later on, especially with the drug interactions in pregnant women, because all the drugs that interact with dolutegravir are drugs we use commonly during pregnancy. Okay. And again, you've gone through this slide with Julia, is that in women of childbearing potential, assure that they're pregnant, and saying they're not pregnant is not a verbal answer. You need to do a pregnancy test, and you need to record that pregnancy test in the patient's file. The patient had a pregnancy test, and it was negative. Okay. And then if it's somebody who's desiring a pregnancy, again, it's the informed choice to say, these are the risks of using dolutegravir, these are the benefits. TEE is not going to be phased out. Just because we are introducing TLD doesn't mean there will not be TEE anymore. It will still be available. Women will still have a choice of using it. And we've talked again and again about the overarching issue of switching, is that the patient needs to be virally suppressed. We'll talk about viral load monitoring in pregnancy. And remember again, there wasn't this emphasis previously about this viral load between 50 and 1,000. But the evidence is coming up that with low-grade viremia, there's still a high risk of developing resistance. There's also a risk of transmission. Remember, if we're talking about the pregnant woman, the immediate important person is the baby. And there's also the partner. The partner might be HIV negative. And we've talked again about the risk and benefit, contraception, drug interactions, and their new side effects. The new side effects is important because we know that with pregnant women, they may have hyperemesis, they may be intolerant of all sorts of things. And on top of all that, you add switching of dolutegravir, and they might develop new side effects. And we'll talk about the algorithm in terms of if the viral load is more than 50, how do we manage them? So these are specifically important in pregnant women. I just want to touch on the bit about anticonvulsants. So epilepsy, we call it a disease of threes in pregnancy. Anyone know what the disease of threes is? Three. Not tree, the tree outside, but three. So a third get better, third stay the same, a third gets worse, meaning that a third of patients who are pregnant and are epileptic will likely get breakthrough seizures during pregnancy. So again, we need to be cautious about switching of anticonvulsants in pregnancy. If we're saying that carbamazepine is a common anticonvulsant we use in pregnancy, and we're saying that it interacts with dolutegravir, so you want to switch it to lamotrigine, and lamotrigine is one of the drugs we don't have that much evidence about it in use in pregnancy. So my suggestion is that if somebody is on anticonvulsants and they're well controlled, please don't switch during pregnancy because they're likely to get through breakthrough seizures. But counsel the woman again because it is an informed choice. Same thing with diabetes. Pregnancy on its own increases the risk of a pregnant woman developing diabetes, and they may develop gestational diabetes. And your diabetes control also gets worse in pregnancy. So pregnant women tend to develop hyperglycemia if they are diabetic. So again, we do use metformin in pregnancy, but if you can't be sure about the safety of metformin, what is the alternative? Insulin. So we do use insulin in pregnancy. So keep those things in mind, is that if you can't control her diabetes with metformin, you can't increase the dose. Rather err on the side of caution and give her insulin, and then you can switch her after the postpartum period. So I want to put a bit of a spanner in this diagram and say, we're saying if somebody is using iron, we're using iron once a day. What happens if you've got somebody who's anemic and you're giving iron 3 times a day? So how are you going to suggest the dosing schedule? Because if they're taking iron once a day, it's easy. And also the calcium, can you not combine and give them a gram of calcium at a time instead of splitting it? But then if they're taking iron 3 times a day, how are you going to dose them? And this is a reality because remember, HIV also increases the risk of anemia in pregnancy. So they're likely to be prescribed more than 200 milligrams of iron tablets. So I want to hear some suggestions. I know a lot of people in the room, so I'm going to start asking names. There's a hand this side.
Yes, I was going to say, with the latest hypertension guideline, Prof. Bob Patterson recommended that 500 grams is sufficient for anything.
Okay.
So there won't be any need for 2,000.
Okay. Thanks so much for that. Everyone hear that? Okay, so then we sorted out with calcium. And remember calcium as well, you don't need to have exact dosing. So a patient can choose what is the convenient time to take it, and they can take it isolated from her dolutegravir. Okay? Another hand? And what do we do with the higher dose of ferrous sulfate?
So we usually say they must give it 4 hours apart.
Okay.
The calcium and the iron.
Okay, so I'm saying now you've got a pregnant woman who's also considering taking dolutegravir, who's also taking calcium to prevent preeclampsia. Okay, so how do you schedule those 3 drugs? So you're giving iron once, 3 times a day. You're giving calcium once a day. You're giving dolutegravir once a day. But then you can't combine the iron and calcium. You can't take the iron and dolutegravir without food. There's a hand here.
I don't think there's good evidence for iron 3 times a day at the moment.
Mm-hmm.
And a lot of people suggesting, especially pregnancy, because of the gastritis and other things,
Mm-hmm.
is to rather make it a BD dose.
Mm-hmm. Okay.
I think I would go for that.
You'll go for a BD dose. Okay, that's fine. Anybody else with any suggestion? So the BD dose would be iron in the morning, depending on when they're taking their dolutegravir. So let's say they're taking their dolutegravir in the morning. So you'll say dolutegravir, iron, food. And then you'll say calcium, midday. And then at night, iron on its own. Okay? Everybody agree? Because this scenario here, it's saying somebody who's taking iron once a day, and they can take their calcium either in the morning or in the evening with food. Okay. Anyone want to add anything else? No? Khomot?
I would actually want to ask to say, I'm now saying what happened with TDS, that there's no situation where
Well, this is quite debatable because there is the absorption issue. A lot of, when you give iron, especially if you give a higher doses, the tolerance, it does cause gastritis, and they may be vomiting as well. And then the issue is, do you give it 3 times a day? Do you halve the dose? Because one of the suggestions is that they take smaller doses more frequently to prevent the irritation. And there are times where you even go to giving a suspension just because they can't tolerate. So again, that's where you would individualize. So instead of giving it 3 times a day, you give twice daily. And then it simplifies your dosing schedule a little bit. Okay. Anybody else?
If you are giving it twice daily,
Mm-hmm.
at the end of the day, are you going to give the same amount of iron the person was supposed to take when she was on TDS?
Yeah.
Or you just give?
Again, it depends on the tolerance, because remember, you higher the dose of iron that you are giving, the more likely to cause irritation, gastric irritation and vomiting and non-absorption. So that would why, so if she was on given 200 milligrams TDS, you can break the iron tablets. And then they can take half the dose in the morning, half at night. Louise?
So, a spanner in the works, what if she's got TB and she has to be on the extra dolutegravir? Then would it be preferable to rather change it to TEE?
So what do you think, Louise? Dr. Gilbert? What is your
I
suggestion?
think I'd rather change it to TEE.
Anybody else in the room? It's the safer option and the simpler option, because now you're sitting it with having to give your dolutegravir twice a day. You've got TB treatment, you've got the iron, you've got the calcium, you've got antacids as well, because almost every pregnant woman has heartburn and is using antacids. Okay. And what is the critical key drug in this whole mix? Your TB treatment is critical. Your antiretrovirals are critical. Yeah. Sorry there? Even the iron as well, but I'm saying if you do have an option of using your TEE, which doesn't have all these interactions, you don't have to have all these dosing schedules, doesn't interact with your TB treatment, my suggestion is that give TEE.